Let's go on for the last word presented by Marinus van der Ploeg from Netherlands. Please.
Thank you very much for the good pronunciation of my name. That's always a hard thing. Ploeg or whatever. Thank you very much, dear Chairman. Thank you for the opportunity to present our results of the Cupido-1 study. Dear colleagues, we did a randomized controlled trial comparing vaginal prolapse repair with or without a midurethral sling in women with pelvic organ prolapse and coexisting stress urinary incontinence. I have no conflict of interest to declare. The aim of our trial was to study whether the combination of vaginal prolapse repair with a midurethral sling reduces the risk of postoperative stress incontinence in women with pelvic organ prolapse and coexisting stress urinary incontinence before surgery. Therefore, we conducted a multi-center randomized controlled trial between 2007 and 2011. Eligible were women that consulted us because of pelvic organ prolapse and had also complaints of predominant stress incontinence. And stress incontinence was defined as the symptom or the sign of stress incontinence, and the symptom has to be present more than once a week. And that was measured by the UDI. Primary outcome was subjective stress incontinence at 12 months, measured by the Dutch validated UDI. Secondary outcome measures were, among others, objective stress incontinence and treatment for persisting stress incontinence like physiotherapy or surgery. We did a web-based randomization and 63 patients per group and with 63 patients per group we would have 80% power to detect a 20% difference in subjective stress incontinence at 12 months. And analysis were conform intention to treat. 138 women were randomized, 67 for the combination surgery and 71 for prolapse surgery only. In the combination group were 3 randomization mistakes and 1 unknown case. And excluding these cases, 63 patients were analyzed in the combination group versus 71 in the prolapse group. 133 patients were available for the 1-year outcome of subjective surgery, so a very low follow-up, loss to follow-up, and 85% of the patients attended the 12-month visit and were available for objective outcome measures, and this was equally divided between the 2 groups. Also, baseline characteristics were comparable, for instance, for age, BMI, prolapse, objective and subjective stress incontinence, and UDI domain scores. Looking at stress incontinence, women that underwent only prolapse surgery had about 3 times more risk of having persisting subjective stress incontinence, having objective stress incontinence, or needing additional therapy for stress incontinence like physiotherapy or surgery. 11 women in the prolapse group underwent a midurethral sling for persisting stress incontinence within the first year after primary surgery. The number needed to treat to prevent 1 woman having persisting subjective stress incontinence was therefore 2.5, and for receiving subsequent midurethral sling was 6.3. The UDI domain score for stress incontinence was better after combination surgery, and we did not find differences for the other UDI domain scores between the 2 groups. Surgical complications were more frequent in the combination group. 6 complications were identified as MUS-related. This difference was not statistically significant, but that is probably due to the small patient numbers. The MUS-related complications were 2 vaginal tape exposures, 1 bladder perforation, 1 erythrolysis because of dysfunctional voiding, and 2 persisting groin pain and partial tape removal because of that pain. The number needed to harm was therefore 10. In conclusion, and this may very well be used for the counseling patients with prolapse and coexisting stress incontinence, we found almost 3 times more persisting stress incontinence and therapy for persisting stress incontinence after prolapse surgery compared to combination surgery. 60% of the patients undergoing only prolapse repair needed a midurethral sling within the first year after primary surgery. but we also found more adverse events after combination surgery. Thank you very much.
Thank you, Marinus. So the paper is open for discussion.
Can I ask you questions while the others decide to make a question? From the the overall screen patients, do you have any idea of the rate of women who didn't accept to take part of the study because they preferred?
No, that's a very good point. No, we didn't.
No.
Because of a lack of finance.
Right.
Yeah. No, we don't know.
There's a question.
Keris Glazen from Aberdeen. May I congratulate you on a lovely trial, and for once I'm not going to say the numbers are too small because you set your sample size as a difference of 20%, and I think you achieved your sample size as well. My point is, however, that the 71 women in the control group who did not receive the sling, 40% of them were dry just with the prolapse surgery alone,
yep.
And many people would just have put a TVT in, and even though 60% were incontinent, only 11 of them were so bad that they said, "Oh, I really do need a sling." So, in fact, that's I think almost 90% of the women in the control group were sufficiently cured by the prolapse surgery alone.
80%.
Okay, well. Sorry, I'm looking at 11, yeah, okay. So by the prolapse surgery alone, which means that that 80% who normally would have had a TVT would have been over-treated, the same point as they made earlier.
Yeah, that's right.
Yeah.
The problem of the problem with combination surgery is always the balance between over-treatment and under-treatment, and that is what you have to counsel the patient, and
yes.
That's the only thing.
And it was also.
I'm not saying.
Well, can I just rephrase? Don't you think it would be better to say over-treatment or treatment in 2 steps?
I don't think you can say that. There's also under-treatment, and when patients have clearly combined problems, or when patients are referred to you because of stress urinary incontinence instead of prolapse, and you find also a prolapse, that's a different patient from the patient we did,
yes.
And that's an essential thing, I think.
Who were dry, exactly. But still, even though they were wet, you would over-treat 80% of them.
Yeah. Thank you.
Thanks. I may have missed it, but could you point out again, did you use, in your prolapse surgery, do you use anterior compartment anchored mesh?
No, only few. There were a few anchored mesh.
Yeah. That's fairly likely to be a confounder, because I was surprised too at the
there were only, I don't know the number exactly, but there were maybe 4 patients, and they were equally divided into 2 groups. Yeah. So there was only a very small group, and most of the patients had classical repair.
Okay. Now, it's a neat trial. It's well done. It's highly plausible. I congratulate you. I just wonder whether in the end, to the clinician, to us, whether, you see, there's major limitations in the utility of such data, and you've pointed it out yourself just now, isn't it? You just told us about a patient who's obviously at the more extreme end of the population distribution, and we can think of somebody else on the other end, on the other extreme end, and the RCT. In the end, the results of this RCT apply to the average patient. So if you see an average patient in your clinic, then these results apply. But if you see the patient you just explained to us, if you see somebody who's obviously not average, and most people aren't average.
Nobody's average.
Yeah, well, there must be somebody somewhere that's average, actually.
Well, you are not.
Well, that's true. I'm sure you're right. But shouldn't we... I thought that approach with the scoring system from Cleveland Clinic was actually brilliant.
I'm sorry?
Because the scoring system, remember, because what the expert system of your brain does when you see the patient, it is like using an intuitive scoring system. And all that data that we obtain in RCTs really should at some stage go into the construction of such a scoring system. Maybe you can do that.
I fully agree.
Gilbert from Sydney. Did the group who didn't have surgery, did they go off and do the group that didn't have the extra
combination
surgery? Yeah. Did they go off and do any other pelvic floor? Do you know they did no pelvic floor work, they did nothing.
Can you rephrase that question?
I want to know did the group that did not have the extra surgery, did they absolutely do no pelvic floor work ever again? Did they?
We don't know. No.
So
we only know the patients who had had physiotherapy or midurethral sling. There was no patient having bulking or anything else.
Because clinically, that group who gets incontinence after prolapse surgery do really well with physiotherapy. They rarely need. Everyone talks about, you should have a sling. Rubbish. Just send them to physiotherapy, and they almost all get better. It's a trial waiting to happen.
But I don't see that in my. Is that true?
I'm making the comment that we think, you failed your prolapse, you've got incontinence after your surgery.
Half of the patients.
You need a sling. You don't need a sling. You need physiotherapy. Clinically, they do really, really well. That's my impression, and it probably needs to be proven in a lovely RCT, and you could do it here.
But in our group, half of the patients who had treatment had a midurethral sling, so half of the patients were satisfied with physiotherapy only.
But I'm saying after the operation, yeah. So I think we
always
think, they need a sling. They don't always need a sling.
Yeah. Okay. Thank you.
There's one question at the end.
Chris Payne, Urology, United States. Just a brief comment on the idea that's been sent out that if a woman is wet but doesn't need another operation, that's really okay. I mean, I think that's up to the person, and you need to think about that before the surgery. There are many women and patients who have other diseases who make a great investment in having an operation and psychologically are simply not going to come back and have a second operation, even if we as surgeons think it's a minimal little procedure. So we can't count them as being okay just because they didn't choose to come back and have that nice, easy secondary tape procedure.
I fully agree.
Elisabetta.
Just an information. In your outcome evaluation, did you have data on the type of post-operative incontinence, in the sense that if there's a mixed incontinence or a stress incontinence or urgency incontinence? Because I think that it's another important point.
We didn't find any difference between urgency incontinence in the two groups. There was no difference in treatment for urgency incontinence or overactive bladder, so there was no difference. But post-operatively. But there was a difference for the UDI domain scores. No, there was no difference for the UDI domain scores for overactive bladder also. Yeah.
Okay, I'm Dr. Xiao from Taiwan. I have one question. Is your group include a case of occult incontinence?
No, we didn't have any. That's the other study, the Cupido of the Cupido 2 study. No, there's no occult stress incontinence in this study.
We have one article will be published, I think. We use the PET test that we find you can use the PET test as a tool to screen the patient before surgery.
Yeah.
That may eliminate the additional surgery for the SUI.
Okay, thank you.
Thank you. Question from the...
Can I just make a comment? I mean, you just presented a really excellent frequentist clinical trial with beautifully conducted with great results. And then instantly all the haggling starts and all the what-ifs and, well, if it had been this kind of patient and that kind of patient, which I think is a wonderful paradigm or metaphor for the fact that Fisher frequentist statistics are a load of old rubbish for this kind of analysis. And that we, the people practicing with real live patients, we need to start shifting to the Bayesian approach. And if the Bayesian statistics is able to filter your spam on your email account and it's able to run these complex games on an Xbox, then surely we can start applying it to medicine and making greater sense. So I'm appealing for the banishment of frequentism and the inception of Bayesian thinking into this society.
How do you do that?
What Bayesian statistics? Go for it. Oh, yeah, okay. I won't go into the complexities, but the nowadays with the microprocessors that we've got, I was about to say it was a piece of piss. Well, I've said it. It's dead easy. All right, get on with it.
Well, thanks.
Okay. Last question.
You mentioned that the anterior repair was, in most cases, a classical repair.
Yeah.
Were there technical details of that repair that explained to you why the subjective and objective stress incontinence resolved in many of these patients?
No, we don't know.
May I just add one point? I'm Dr. Eger from Germany. We also had the same question, and we found out that one of our colleagues did the so-called Kelly stitches.
Yeah.
And in those patients, he was the only one who could cure
we excluded the Kelly application, so it wasn't allowed. We just did a classical anterior repair, no Kelly applications.
But it was standardized anyway in terms of procedures, sutures, and...
Excuse me?
The procedure was standardized among the centers.
It was standardized now. Well, the only standardization was that you had to do an anterior repair, but there was it was not allowed to go beyond the bladder neck. So,
right, but in terms of,
because we didn't want to have any placation of the bladder neck or placation of the urethra in this study. We just wanted to compare prolapse surgery to combination surgery, and not prolapse surgery with a classical repair of incontinence to combination surgery.
Okay.
Okay.
Thank you. Thank you very much.